Good morning, everyone. Today we will be discussing about photodermatosis. So, introduction about it. It is to understand the pathogenesis, the diagnosis, as well as the treatment of photosensitive disorders affecting the skin. It is mainly to know how sunlight will react to the skin. Sunlight has both beneficial and harmful effects on the skin. The benefits are basically the synthesis of vitamin D3 and setting of internal clocks. The adverse effects being photodermatosis, skin cancer, as well as sunlight-induced aging of the skin. So about sunlight and UV radiations. The sun emits ultraviolet radiation, that is UVR, visible light, as well as infrared rays. The UVR, that is ultraviolet radiation, it's subdivided into UVC, which has a nanometer, which has about a wavelength of less than 290 nanometers, UVB, which is 290 to 320 nanometer, UVA, which is 320 to 400 nanometer. So UVC has only less than 290, whereas UVB and UVA have more than that. So UVA is further subdivided into UVA1 as well as UVA2. So UVA1 has 340 to 400 nanometer and UVA2 has 320 to 340 nanometer. The spectrum of visible light is about 400 to 700 nanometer, and that of infrared rays about more than 760 nanometers. So infrared has the most maximum number of wavelength, which is about more than 760 nanometers. The various environmental factors which influence the amount of UVR, that's ultraviolet radiation, received by humans include a lot of factors like the time of the day, mainly it will be more towards the mid of the day, like noon time is more. Seasonal weather changes like summer season will be more. Altitude as well as surface reflection. So there are various factors which will vary, which will influence the amount of the UV radiation that enters the skin of the body. Window glass actually blocks UVB rays, but it allows UVA to pass through it. UVC has got germicidal action and commonly it's used for water purification. So this water purifiers usually use UVC to destroy the germs and all the microorganisms to make the water pure. So the different UV rays have got other effects also, other than many other useful factors also. UVA and UVB rays are responsible for various photodermatosis. UVA light penetrates into the skin and is involved in sun tanning. It tends to suppress the immune function and implicated premature aging of the skin. Whereas UVB rays do not penetrate the skin as far as UVA rays and is responsible for sunburn reaction and can also cause photoaging, skin cancer, as well as cataract. Certain molecules in skin called chromophores, they are the ones which absorb UV light from the sun, which reaches the skin, and this is responsible for photosensitizing reactions. Now, the different normal responses of the skin towards sunlight are the various skin phototype depending on the response of the skin to sunlight. We can say they can either undergo erythema or tanning or vitamin D synthesis, photoaging, hyperplasia. So what is erythema? Erythema is an acute reaction over the skin which occurs due to sun exposure. Tanning is the hyperpigmentation that occurs on the skin following sun exposure. Vitamin D synthesis is where the skin will synthesize vitamin D in the epidermis level. Photoaging is the accelerated aging changes that occurs in the skin when exposed to sunlight. Hyperplasia is a thickening of the skin in the stratum corneum level of epidermis following exposure to mainly UVB and UVC. So we classify photodermatosis into different types. So etiological classification, basically etiological classification means what caused it. So what caused the photodermatosis is, one is xenodermatosis, means it's genetic factors involved. Example for this is xeroderma pigmentosum and Bloom syndrome. Then it can be idiopathic, that there's no particular cause for it. Then that is idiopathic photodermatosis. In that we can have PMLE, that's polynomial light eruption. We can have chronic actinic dermatosis, solar urticaria. Then we have photocontact dermatitis, and we have phototoxic and photoallergic dermatosis, which are caused by drugs. Then any kind of metabolic disease inside the body can also cause photodermatosis. Example being porphyria and pellagra. So it's because of deposition of certain substances, metabolic substances in the skin, which will cause photodermatoses. Then certain tumors or carcinomas can produce photodermatoses. Examples of which are actinic keratosis, basal cell carcinoma, and squamous cell melanoma. Squamous cell carcinoma as well as melanoma. Then there are certain diseases that are aggravated by sun exposure and can cause melasma. So melasma is mainly seen on the face, hyperpigmentation seen. So in this comes lupus erythematosus, rosacea, acne vulgaris, and pemphigus. So this photos of PMLE, where we can see that mainly it is on the sun exposed areas where we can see there is formation of skin lesions. It's evident that the patient's exposed part only has the problem, and the non-exposed part where his clothes are there are no skin lesions, there are no skin problem. So it's because of exposure to sunlight, phototoxic photodermatosis. This is a case of xeroderma pigmentosum with malignancy. So here there is problem with DNA repair mechanism causing problem. These patients will be more prone for phototoxicity, photodermatosis, because they have impaired DNA repair mechanism. Then this next figure is a photo of squamous cell carcinoma, mainly occurring on the sun exposed area over the face, over the lips. This is another condition of photoallergic dermatitis seen on the sun exposed area of the face. The photo of phototoxic dermatitis. Then we have pellagra, like we said before. Here also in mainly sun exposed areas, metabolic cause of photodermatosis. Sun exposed area, we can see hyperpigmented plaques. This melasma, where we can see hyperpigmentation over the face. These are all sun exposed areas. Here we can see porphyrias on the left side. On the right side, we can see rosacea. So all these people have burning sensation when they get exposed to sunlight. They're very much sensitive to sun exposure. Then CAD, chronic acne dermatosis. So also even exposed to even artificial lights can produce problem in these people who have tendency to develop chronic acne dermatosis. This is CAD with Wilkinson triangle behind here. So what is PLE or PMLE, polymorphic light eruption? It is the most common idiopathic photodermatosis. Female are more affected than men and can be seen in any age group. Then about the etiology and pathogenesis, the exact cause of PML is not known. It's probably because of immune problem. It's immunologically mediated. Delayed type of hypersensitivity reaction to unknown sunlight-induced antigen is seen in the skin. And the rays responsible for these are UVA and UVB. Clinical features. Itchy rash can be seen on the sun-exposed part of the body. The face is normally spared because of hardening due to repeated sun exposure. The rash classically develops within minutes to hours of sun exposure, and various morphological types can be noted. That is why it's called polymorphism. So in India, the commonest type is basically pinpointed group, lichen knitted as light papule and papular-black, papilla vesicular, eczematous, and erythema multiforme. So Indian type of skin, Indian type of climatic changes can produce lesions which are more like grouped papule. The grouped papule or grouped papular plaque can be seen, or papular vesicular eruptions can be seen. That is normally what we see in Indian skin in this PML. In children, the face is commonly involved as scaly, hyperpigmented plaque and hypopigmented rim. How do you diagnose PML? You diagnose it based on history and clinical finding. So patients will say that they get more problem, more symptoms, more itching, or more burning sensation when they get exposed to sunlight. So that is the most important thing they'll say. That is the most important history of PML. And they'll be having mainly on the sun exposed areas. Lesions will be present mainly here, sun exposed areas. And so diagnosis we can understand by history as well as clinically. We should look where all the lesions are there, whether lesions are present inside the exposed non-exposed areas also, or only in the exposed areas like hands, face, and wherever it's exposed, lesions are there or not. So we have certain differential diagnosis of PMLE. We have acute and subacute cutaneous lupus erythematosus. We have solar urticaria, erythropoietic protoporphyria, atopic dermatitis or seborrheic dermatitis. ANA, porphyrin level should rule out all the above conditions. We should do an ANA, basically antibody testing, and porphyrin can check. ANA we can do to rule out lupus erythematosus. Porphyrin we can check to rule out porphyrias. So we should check all this to rule out the above DDs of lupus erythematosus, urticaria, photoporphyria, and all that. So these are certain DDs we should think about when we see a case of PML. Now, treatment-wise, most important, we should do photoprotection. We should basically we should prevent the exposure, more exposure to sunlight. And we can also do topical steroids. Steroids we can give depending on where the lesion is present. If the lesion is present on face, we can give a low potency steroid. If it's present on hands or in forearm or any other parts of the body, we can give a moderate potency steroid. We can do a desensitization where short prophylactic course of narrowband UV rays as well as oral Pura can be given. It's a prophylactic course. It's called desensitization. So this is how we treat a patient. We should do photoprotection, give steroids as well as do desensitization. That's our PLE or polymorphic light eruption. Next we have CAD, that is chronic actinic dermatitis. So CAD is actually characterized by abnormal photosensitivity to UV rays as well as visible rays and manifests mainly as dermatitis on the exposed parts of the body. So many patients may have dermatitis on the covered areas of the body. Like some people can have covered areas also. So what about the etiology and pathogenesis of the disease? Due to hypersensitivity response to unknown photo-induced allergy in the skin. So we're not sure what exactly is causing the problem. It's because of an unknown photo-induced allergy in the skin. And it also shows multiple contact allergies to exogenous sensitizers. So these patients who are CAD are very much allergic to even small things. They are very much allergic to any sort of exogenous sensitizers. And it is said that men are more commonly affected than women. So clinical features. We can say that there is formation of itchy rash on the exposed part of the body, like the male exposed part means can be face, can be in the V area of the chest, like when people put t-shirts or shirt or like they will cover the other parts in the V area of the chest. They can have problem. They can have it in the neck. They can have those smooth hands, or they can also have in the scalp. So these exposed parts of the body, itchy rash can happen. Areas like the upper eyelids, the skin creases, submental area, retroauricular region, and finger web space, which are photoprotective sites are usually spared. So any kind of fold like skin crease or submental, so it's below the chin, retroauriculars behind the ear, and finger web space. So all these areas are actually not exposed sun much. So these areas which are protected from sun are usually spared in CAD. That is the most important finding we see in CAD. Now, the triangle area behind the earlobe, known as Wilkinson triangle, is spared in CAD. We saw Wilkinson triangle before. I'll show it. So this is Wilkinson triangle. It is seen behind the earlobe. Since this part is also protected from sun, they also will be spared in CAD. In this patient, we can see that the upper eyelid of this patient is spared. See, we can see the upper eyelid is not affected. The submental area is not affected. It's not visible in this photograph. Then other parts are usually affected. See, the forehead, cheeks, all these parts are actually affected. But here the area behind the ear is also not affected, and that's called Wilkinson triangle. It's a triangular part behind the ear. It is said that in long-standing cases of CAD, even covered sites may get involved eventually. So usually covered sites are not involved, but in long-standing cases, they may also get involved. In about 50% cases, they can progress themselves to exfoliated dermatitis. So, yeah. Then we have differential diagnosis of CAD. DDs of CAD is based on history and clinical examination findings. Photo testing can help us to confirm diagnosis. So diagnosis we can ask, like the other case, we can ask whether it's the problem is more when they get exposed sunlight or not. We can also check where on lesions are. Like I said, it will be more on the sun exposed areas, and it will be spared on areas like I said before, over the upper eyelid, over the submental area, over the digital interdigital web space, and all these areas it will be spared. Skin creases will be spared, and the Wilkinson triangle. So we should look whether these parts of the body are spared, and usually the lesions are mainly present in sun exposed areas or not. And we can do photo testing to help us in confirming the diagnosis. Then we have the DDs. Basically, DDs are airborne contact dermatitis, ABCD, photo contact dermatitis. Then we have atopic dermatitis and seborrheic dermatitis. So these are the other DDs we should think about. But it's each of this which can differentiate from CAD based on certain factors. For example, airborne contact dermatitis. In this case, skin creases, upper eyelid, submental areas, and retroauricular areas are inborn. But in chronic active dermatosis, they usually spare. Because airborne contact dermatitis is caused due to different type of allergy. So these bacteria they can get deposited anywhere in the body. So they can get problems anywhere. They can get problems in skin crease, fold, upper eyelid, retroauricular area, anywhere they can get lesions. But CAD is because of photo exposure. So any areas which are spared from photos, spared from sunlight, will not develop any problem. So that is how we differentiate between airborne contact dermatitis as well as CAD. Okay. So like I said, the covered areas are involved in ABCD, but they are normally spared in CAD. So airborne contact can affect any part of the body, but CAD will affect only those parts where sunlight can enter, sunlight can reach. So covered areas, sunlight cannot reach. So in CAD, these areas are spared. Then when we do photo testing, it's normal. Whereas in normal MED is seen in ABCD. But in CAD, lowered MED is seen to UVB as well as UVA. So photo testing will be positive. Photo testing will be showed lower in CAD, whereas it's normal in ABCD. Next, how we differentiate phototoxic dermatitis and photoallergic dermatitis. So like the name suggests, photoallergic dermatitis is hypersensitive disorder. It is because it's a type 4 hypersensitive disorder. But phototoxic, like name suggests, it is a non-immunological. And phototoxic dermatitis is more common compared to photoallergic dermatitis. And phototoxic is more like a sunburn-like reaction, usually what we see. In photoallergic, we usually see an eczematous type of lesion. And phototoxic, we can do a clinical history examination. We can definitely understand phototoxic dermatitis. But photoallergic dermatitis, we should do a photo patch test to confirm diagnosis. Then general measures regarding treatment, we can say that education of patients is required regarding the disease. Then we should avoid sun exposure between 10 a.m. and 4 p.m. because it is this time that UVR rays is high. Then we can do physical protective measures like umbrella, caps, and also we can wear full clothes. Window glass protect the scene from UVB as well as UVA. We should avoid photosensitizing drugs like quinolones and phenothiazine. So basically the main thing we should tell the patient, we should counsel the patient properly about the harmful effects of sunlight on the body. They should avoid exposure to sun between the peak time of when the UV radiations is high. That is between morning and evening. That is between 10 a.m. and 4 p.m. They should avoid going outside. They can use protective measures, like I said, they can wear full clothes, or they can use certain things like umbrella, cap, and all that to prevent sun exposure. And they should, if they are on certain drugs like photosensitizing drugs, it's better to avoid those drugs. But if at all they happen, if they should do physically, they should avoid sun exposure. So most important part in this treatment part in this photodermatosis is application of sunscreen. So sunscreen, it acts by reducing or preventing the contact with UV rays, either causing reflection or by absorption. Okay, so there are different types of sunscreen. We have chemical and physical sunscreens and all that. Physical sunscreen will just cause reflection of the UV rays when they reach the skin. But chemical sunscreen, they will absorb it absorb the sunscreen in the skin, absorb the UV rays in the skin, and it's converted. So that is how these two act. So physical and chemical sunscreens are there. Basically, any method they do, what they're doing is preventing the contact of UV rays over the skin, preventing UV rays from entering the skin. So sun protection factor SPF said that higher the SPF, higher the protection, and it said the Indian skin requires a minimum of 15 SPF. So like I said before, we have chemical sunscreen, physical sunscreen, combined sunscreen. Chemical sunscreen will absorb the UV rays and will convert. So we have UVA protective, UVB protective. UVB protective are PABA, PABA, salicylates, and cinnamons. UVA protective are benzophenone, avobenzone. Physical sunscreens are zinc oxide, titanium dioxide, and combined ones, they have both physical and chemical, both factors are there. So methods are used, we can say that they should apply the sunscreen about 20 to 30 minutes prior to sun exposure, and they should reapply the sunscreen every 3 to 4 hours for optimal benefit. We can also use certain systemic photoprotective agents like ascorbic acid, psoralen, beta-carotene, and anti-malarial drugs. So that's our sunscreen. So we should tell the patient that they should apply it half an hour before going outside, and they should keep on reapplying it every 3 or 4 hours until the sun sets down, until 4 o'clock minimum evening, to get maximum benefit. So that is how they should use it. More than SPF, most important. SPF are very important. The most important benefit of sunscreen will come in the way of application. Key points in photodermatosis are there are various etiologies causing the photodermatosis, like xenodermatosis, idiopathic photodermatosis, phototoxic and photoallergic reactions, metabolic conditions, and skin tumors that are aggravated by sun exposure. Like I said, squamous cell carcinoma is mainly seen. That is why SCs is mainly seen on the sun-exposed areas of the body, like the face. Then idiopathic photodermatosis also I already told, the polymorphic light eruption and all that. And metabolic conditions also I already told, about porphyrias, pellagra. These are some of the factors. So there are different causes for photodermatosis, and what will be the cause? The main thing, like I said, the treatment is, like I said before, like photoprotection is very important. Then, so what is PLE? PMLE, or polymorphic light eruption? It is characterized by papular, plaque, or eczematous lesion, like I said before. Like in case of Indian skin, it will be in the form of lichen intervals. There will be basically there will be grouped papular plaque seen on the sun exposed areas mainly, like the mainly of the like V shape of the chest or the neck or the arms, forearms, wherever the sun is exposed. These are the areas where you usually get these kind of lesions. So it looked like lichen intervals. The lesion will look similar to lichen intervals, but lichen intervals can come anywhere, mainly like the bone, like usually for elbows and all that. But the PMLE usually comes mainly sun exposed area. Okay, so usually that is how PLE will look like, and that's very commonly seen. So next is CAD, or chronic acne dermatosis. CAD mainly affects elderly population, mainly affects old man, and delayed hypersensitivity reaction is what is happening here. Basically, eczematous lesions are usually what we see. Like I said before, the lesions on the forehead, over the face, on the forehead, over the mainly sun exposed area, they can happen. But most important factor CAD is that it will not be seen over the upper eyelid, over the submental areas, over behind the earlobe, that is called the Wilkinson triangle. Then they will also not seen between the fingers. These are the areas where sun may not be exposed. So these areas will not be involved in CAD, but these are involved in ABCD, or airborne photodermatitis. That is how we differentiate both. Then we have phototoxic reaction, which resembles sunburn and is usually non-immunological. Like I said, it is non-immunological. But photoallergic is immunological. It's caused a type 4 hypersensitivity reaction, and we see eczematous lesions. But phototoxic is non-immunological. It's just a toxic, like phototoxic agents, and resemble like sunburn, or usually when exposed to a lot of sun, they can get sunburn. That is not related to any immunity. But photoallergic is related to hypersensitive reaction. So approach is like I said before, we should take a proper history of the patient. We should ask when is the itching more, whether while exposed to sun is it more, or it is also whether it's seen also on the non-exposed areas of sun. And we should ask like where itching when is more common, where itching is more at morning or night. Like then we should take a detailed history from the patient. Clinically, we should look whether lesions are seen only on the exposed areas, or on the non-exposed areas also, and like the covered areas also or not. Investigation, like I said, we should do a photo testing and check the MED level, and then what the most important, we should tell them to use sunscreen, physical or chemical or combined. It doesn't matter what type of sunscreen it is. Most important factors of sunscreen is that the way of application should be correct. It should be applied half an hour before going out, and should be reapplied. And Indian skin needs an SPF of minimum 15. The more the better. The more the SPF, the greater will be sun protection. So preventing the physical UV rays to enter the skin is most important aspect of management of any type of photodermatoses. So we'll go through the whole thing, whole photodermatoses one more time. So we should know about the wavelength of UV radiations, the different types of UV radiation, UVA, UVB, UVC. Then UVA and UVB rays are responsible mainly for dermatosis. So how does the skin respond to sunlight normally? By erythema, tanning, vitamin D synthesis, photoaging, and hyperplasia. We classify photodermatosis depending on the etiology, depending upon the cause, into xenodermatosis, idiopathic, then photocontadermatitis, then metabolic causes, tumors, and then there are certain diseases that are exposed, that there are aggravated increase with sun exposure. Like I said, like all this, like melasma, pemphigus, acne, rosacea, LE, all these are aggravated by sun exposure. So this is, like I said, PMLE, where lesions seen in exposed areas. Pseudomyxoma, squamous cell carcinoma, pellagra, melasma, like I said, CAD, Wilkinson triangle. Hope all of you understood. It's like PMLE very common in OPD. We see a lot of PMLE cases. It's very commonly seen. Then we have CAD. Like I said, some areas, these are the areas which are spared in CAD: upper eyelid, skin crease, submental area, retroauricular region or the Wilkinson triangle, finger web space. So diagnosis, like I said, should be based on history, examination, which differentiate ABCD and CAD. We should also know how to differentiate phototoxic dermatitis from photoallergic dermatitis. Treatment, again, counseling, physical barriers, avoid photosensitizing drugs, use physical protective measures. Sunscreens, like I said, there are physical and chemical type sunscreens. So different sunscreens have different protection, like UV protection, UVA protection. They have different type of protection. Chemical absorbs UV rays. Physical will just reflects with UV rays. Whatever be the type of your sunscreen used, main thing is how to apply it. Apply 30 minutes prior to exposure and reapply every 3 or 4 hours. Systemically, we can use photoprotective agents if the patients are still not getting infected, then if the sunscreens is still not useful for them, only then we'll give photoprotective agents like psoralen, vitamin C, like ascorbic acid, beta carotene, all that. So these we can tell the patients also to take more vitamin C products, carrot and all that. And also we can tell dietary modifications also to these people. So those are the main things, key points like I said. Sunlight has got beneficial as well as bad effects on skin. Beneficial, like we said before, it is very much in a vitamin D synthesis. There are a lot of other many use of sunlight on the skin. But the problem with this sun exposure is, like I said, these kind of photodermatitis can happen. They can have aging, premenstrual, sudden aging of the skin can happen. They are more exposed to, they more have more chance to develop skin cancer. It's mainly seen Fitzpatrick type 1 and 2. Those people have more chance to develop skin cancer. Then they can, yeah, this is the main thing. Then certain diseases which get aggravated by sun exposure, like I said, melasma, rosacea. All these diseases can get aggravated by exposure to sun. So basically, sunlight has got both beneficial as well as bad effects on the skin. So whatever be the cause, main important thing is that they should protect themselves from sun. Sun protection is good even for normal people who are not allergic to photo. Also, it is good in them to prevent aging and all those factors. Cosmetically also we can tell like that. So CAD is all very commonly seen on OP basis. A lot of old men do come with these problems. It's definitely easy to understand the photoallergic dermatitis because it's mainly on exposed areas, and treatment also prevention of light is most important. So these are the main things that are seen in photodermatoses. So that's all about it. So thank you so much.